Welcome everyone to the ISHLT Pathology Community webinar, The Thrombus That Connects Us. We've prepared an exciting program for you tonight. Please put your questions in the chat. We will answer them at the end of the talks. And without further ado, let me introduce our first speaker, Oksana Volod from the Cedars-Sinai. Oksana, the stage is yours.
Thank you so much. Hello, everyone, and thank you for attending this presentation. Today, I will give you a very brief overview of normal hemostasis and hemostasis disorders related to our discussion. As well, I will briefly touch on a very important entity of immunothrombosis and discuss anticoagulants that are currently used and the laboratory assessment and the interferences. As you can see, normal hemostasis is a very complex process. Probably in a school and university, we still remember a waterfall cascade or this Y-shaped model of hemostasis. However, this is not what is happening and what is our current understanding of hemostasis is. What we use right now to understand is a cell-based model hemostasis, which is actually was developed in 1990s. And the key important points to show here that it shows, in addition to coagulation factors, role of tissue factor bearing cells like monocytes, macrophages, as well as the platelets. So it's not only a coagulation factors, but also cellular elements are essentials in this particular process, in this particular reaction. And it's actually a little bit easier to explain the process in this Y-shaped model, but I just wanted to show you complexity. So if there is any injury or actually even infection, inflammation persist in the system, there is a initiation of the coagulation cascade by tissue factor expression on the tissue factor bearing cells, or actually indirectly in circulation, activating tissue factor and factor 7 through the intrinsic pathway. That leads to a little bit of thrombus formation, which is factor 2. This thrombin activates further intrinsic coagulation cascade, creating much more thrombin, which is generated. And this particular thrombin generation leads to activation of platelets. And platelets are not only essential in primary hemostasis, as we discussed, primary hemostasis, von Willebrand factor issues, but also they serve as the template for coagulation reaction to occur, because platelets are full of phospholipid. And as you can see, coagulation cascade basically settles on the platelet surface, which is stabilizing clot, and with further thrombin and activation of intrinsic pathway, that leads to the fibrin conversion to fibrin monomer, fibrinogen conversion to fibrin monomer. Then fibrin monomers are stabilized by factor 13, cross-linked by factor 13, and the stable clot forms. Then our own fibrinolytic system, through the activation of plasminogen to plasmin, will break the clot. So not an anticoagulant really break a clot, but our own fibrinolytic system. So if there's issue with the fibrinolytic system, for example, the clot that can be even formed physiologically will not be able to dissolve and will stay and persist in the body. In addition to this process, we have our own natural anticoagulants that play an essential role in hemostasis. Mainly, this is antithrombin 3, and antithrombin 3 regulates factor 2, 10, and as well as factor 11 and 9. And also protein C and S complex that inhibit factor 5 and 8. So those are natural process. And if there is no issue, the system is in balance, blood is flowing normally, endothelium is healthy, nothing is really happening. However, as you can see, the risk of factors for hypercoagulability can be pretty extensive. And it includes inherited and acquired risk factors. And I just wanted to point that we always talk and check for inherited risk factors for thrombosis, but the incidence is not as high as the issues with acquired hypercoagulability risk factors. And even patients with a factor 5 Leiden, can they live the whole life having no issues, and then at the old age, obesity, other underlying condition leads to DVT or PE, and then we do hypercoagulable state workup, and we detect that patient, for example, has a factor V Leiden mutation. However, the acquired risk factors are much more common as cancer, oral contraceptive pills. As you can see, list is very long. I'm not going to be able to touch on this long list, but I will only be able to kind of discuss few issues as are related to our current discussion. But again, I just wanted to point out that acquired risk factors play a major role in the hypercoagulability that we see with various states and diseases. And heart failure is a clinical syndrome caused by structural or functional disorder of the heart. And as you can see, annual prevalence of thromboembolic complications by the recent literature is up to 1% of during heart failure. Unfortunately, the currently available data do not support routine anticoagulation of those patients unless they do have an atrial fibrillation. But as you can see, patients with a heart failure, either with reduced ejection fraction or preserved ejection fraction, they are at the risk of the atherothrombotic risk as well as the thromboembolic risk that leads to strokes and pulmonary embolism. And the current thinking is that the phenotype, it may be due to, we still use Virchow triads in discussion of clot formation, but a systemic inflammatory response induced by tissue hypoxia and also increased concentration of prothrombotic factors like platelet activation, elevation of fibrinogen, which is also acute phase reactant, as well as endothelial dysfunction itself without any underlying inherited risk factor of thrombosis can lead in heart failure patients to the issues of the thromboembolic disorders. Now, a current concept of immunothrombosis, as you can see, was first described in 2013, which has been a while ago, but it gained special interest during the COVID infection. And the process actually serves a purpose to describe that the immunothrombosis is beneficial if it's physiological, because the key purpose is to contain pathogens within the early infection, within the vasculature, and preventing dissemination of the infections throughout the body. However, overstimulation of the system during pathogenic process like sepsis, COVID, DAC, TTP, APS, basically lead to aberrant thrombus formation and basically widespread disorders and high mortality. And specifically, again, the issue become more and more apparent in the COVID era. As you can see, the first studies that emerged right away after COVID in 2019 described that patients with the COVID will have usual symptoms of the PEs with the cumulative incidence up to 49%. And even without DVT, usually we think DVT can progress to PE, but in this population of patients, we basically observe more PE. However, they have also this microthrombotic pattern, which was very specific to COVID. And initial thinking was, okay, that COVID itself will activate contact phase of cascade through the factor 12 and kallikrein. This will lead to activation of the inflammatory pathway as well. Also, COVID will stimulate plasminogen activated inhibitor, which actually inhibits fibrinolysis. And this process will lead to fibrinolysis shutdown. And this is what is happening in COVID patient. However, few years later, actually, the first studies that were published, they do recognize that COVID starts with respiratory infection. However, in some of patients, it proceeds to truly this immunothrombotic process. And with initial attempt to limit infection, it leads also to overstimulation of the inflammatory markers, inflammatory state, and that leads to further immunothrombosis. So as you can see, immunothrombosis now is a concept that gets more widespread attention, but still, even with this picture, there is still thinking is not clear what, in addition to pro-inflammatory cytokines, leads to this particular process, specifically in the COVID patients. Now, when we turn to the devices, because again, one of the main topic of the discussion today is mechanical circulatory support, it brings additional risk factors to the patient already hypercoagulable state that they may have during the heart failure. And the devices can be either short-term or durable devices. Through the short-term devices, the most commonly used would be Impella and ECMO, and continuous flow devices are the most commonly used right now is HeartMate 3, and total artificial heart is still used, but basically is not as commonly used as other devices. I'm gonna go very quickly because I don't have too much, but I just wanted to show you that hemolysis, platelet activation, inflammation, device biomaterial, and anticoagulation as well itself can tip patient off the balance, and they also have risk factors for bleeding and lead them to prodrombotic events. As you can see in patients on if it's a durable devices, the risk of thrombosis, pump thrombosis, and stroke is very high. In a patient with ECMO, there is several conditions that potentially can give pro-thrombotic state, especially hemolysis and stress flow, and leads to platelet activation. Leukocytosis leads to tissue factor expression, and there is also factor 13 deficiency. All this lead to the dysregulation of the hemostatic process in ECMO patients. I'm gonna skip through this full slide, but I wanted to show you that also autopsy versus clinical may be very discordant, because on autopsy, in up to 75% of patients, we can see thrombotic events that are not recognized during the clinical presentation. And in terms of the HIT, I just wanted to point out that HIT is, again, very common, not very common, but patients on heparin, that can be patients with devices, they can develop, in addition to other prothrombotic states, they can develop a heparin-induced thrombocytopenia, which is, again, separate talk, but show you complexity of things that can happen in those patients. And in terms of anticoagulations, the most commonly anticoagulants that are still used would be in MCS patients would be heparin. Heparin acts as a direct inhibitor that potentiates effect of antithrombin. We also have warfarin. The warfarin inhibits factors 2, 7, 9, 10 carboxylation. Direct thrombin inhibitors and factor 10 inhibitors are not that commonly used in MCS patients with anticoagulation. And as you can see, the way we monitor anticoagulation in those patients, there's a variety of factors, assays that we use, which would be ACT, PTT, anti-10A. The problem in the laboratory, these assays can have interferences because of the how assays perform, and that can lead to discordant results. And it can be itself one of the factors that leads for thrombosis. For example, patient has the antithrombin deficiency, and heparin is not as effective itself, it's gonna lead to a prothrombotic event. I think I have to wrap up my conversation, unfortunately. If you have additional questions, please post them in the comment, but thank you so much for your attention.
Thank you, and thank you for the reminder to post any questions that you have in the chat. And we're going to go to our next speaker, Gregory Fishbein from the UCLA, who's going to tell us a story about thrombi.
Yeah, thanks very much for that introduction. The title of my talk is Every Thrombus Tells a Story, and I have nothing to disclose. So when a thrombus forms, it has many questions. What am I? Am I real? How old am I? Where did I come from? Are a few, and this will serve as the outline for my talk. Starting with what am I? The definition is a blood clot within the lumen of a vessel or heart or vascular conduit. Clotted blood outside of the circulatory system is a hematoma. And even though people use the term endobronchial thrombus, I just want to emphasize that is not a thrombus. A thrombus should be in the lumen of the vessel or the heart. It comprises red blood cells, white blood cells, fibrin, platelet aggregates, and as they mature, fibroblasts, endothelial cells, and collagen. Am I real? So you have to distinguish a real clot or an antemortem or in vivo clot from a fake clot, like a postmortem clot or something procedural. This can be critical if to make the correct diagnosis. Grossly, fake clots are described as chicken fat and currant jelly in appearance, and real clots are pale tan to dark red and exhibit these lines of Zahn that I'll elaborate on that are the result of laminar flow. So here is currant jelly and chicken fat, and you can see that this correlates with what you see right here, which is a post-mortem clot that has the currant jelly component and the chicken fat component here. And then to the right, you have antemortem clots, real clots, that look much more variegated in appearance. They have a mix of the red and white, and on the cut section, you can even make out what we would refer to as lines of Zahn. This is what it looks like under the microscope. The currant jelly is red blood cells and some white blood cells, and the chicken fat is more platelet aggregates and fibrin. Here's a nice post-mortem clot showing you the separation of the currant jelly from the chicken fat, and here is a real thrombus that exhibits pretty nice lines of Zahn from laminar flow in the body. How old am I? A fresh clot in one day is going to be fibrin and intact red and white blood cells. In the next couple days, the white blood cells tend to break apart with progressive karyarexis and karyolysis. In the early organizational phase, you start to get an influx of fibroblasts and endothelial cells and the formation of sinuses that will eventually become new blood vessels. Later in the organizational phase, there'll be capillary formation, more fibroblasts, hemocyanin-laden macrophages, and collagen will replace the fibrin. And then once you have a chronic or organized thrombus, that's going to be more than 3 weeks out, there's no more fibrin and progressive dense fibrosis as the thrombus is replaced by scar tissue and sometimes also calcification. Here's a fresh clot. You can see this is a pulmonary vein thrombus. Here's a meson trichrome showing you that it's pretty homogeneous, red cells, there's white cells, fibrin, and platelets. There is no reaction between the endothelium of the vessel and the clot at this point. The white cells are intact, and you don't see any spindle cells in there. And grossly, it's a dark reddish brown like you see here. This is a microscopic image showing you that you have these lines of Zahn and just kind of red cells and the fibrin, and then you can tell here that you really don't have much karyarexis. You can see the neutrophils here are more or less intact. So this is a pretty fresh thrombus. Less fresh, in the next couple days, you start to see karyarexis and karyolysis of the leukocytes. Neutrophils begin to appear in the vessel wall, but you still don't really have any spindle cells at this point. And so here you can see all the white cells and the fibrin and red cells. And at higher power, it's pretty clear that you have the pale karyolytic nuclei and then all of the nuclear debris from the karyarexis. You can see that here. So this is about 3 days old. In the early organizational phase, you start to see the ingrowth of the spindle cells, which are fibroblasts and endothelial cells. The thrombus will develop peripheral splits or sinuses that represent early neovascularization, and the free surface of the thrombus starts to endothelialize. Here's an example of these slit-like sinuses that appear. You can see the red blood cells inside of them. These will become new vessels. Here you can see right here that this particular area of fibrin is starting to develop those slits that are going to become new vessels. And at low power, you can't really appreciate it here, but in this clot, at higher power, you can start to see the free surface of the fibrin here starting to endothelialize. So these slits are turning into proper capillaries at this point. And here's another thrombus in the early organizational phase showing that the free surface is lined by endothelial cells, and you start to see these neovascularization occur here. Not really collagen at this point, still fibrin, but the spindle cells have come in and started making new vessels. In the late organizational phase, proper capillaries form, there's more fibroblasts, hemocyanin-laden macrophages, the fibrin begins to be replaced by collagen, and there's progressive fibrosis as the clot becomes a scar. So this picture shows you quite a full spectrum of thrombosis, but what I was hoping to illustrate here is the presence of fibrin admixed with a myxoid collagenous matrix here as it organizes. So this is still in the organizational, it's still organizing because it's got the fibrin here, but you can see that the rest of this is pretty mature and lacks fibrin. And then finally, in the chronic or organized phase, the fibrosis progresses, there's no more fibrin, and it becomes scar tissue, sometimes getting calcified. This is an organized thrombosis, is actually in a donor lung. It's still not completely mature, and there's some inflammation, but you don't see fibrin, so this is nicely adherent to the wall. This is a trichromoelastin stain showing also a mature clot that is adherent to the wall here, and you have something more immature right there. And then as it gets very old, the collagen becomes more dense, and here you can see the elastic layer of an artery that is completely occluded by an old thrombus that's nicely dense. Where did it come from? So sometimes you can tell where a thrombus came from based on its appearance, whether it's an artery or vein or a medical device, or whether it formed in situ or embolized from someplace else. It's said that arterial clots are white because they have more platelets and leukocytes, and venous clots are red because they have more red cells. The artery is a high shear flow environment, so the lines of Zahn are more prominent than the veins, which have low flow, low shear. This is an arterial clot, indeed more white than the venous clot, which is more red. Both exhibit the variegation in the lines of Zahn. And if a thrombus forms on a medical device that's not touching any native tissue, it will actually never organize. You still get karyorrhexis, so you can establish that the clot is 3 days old, but whether it's 330 or 300 days, they all look the same. And so here's a valve from a Thoratec PVAD with a clot on it that will never organize. To tell whether it's in situ versus embolic, we use things like the shape. If it's shaped like a vessel or a chamber where it originated, it gives you a hint. If there's imprints of venous valves, you can tell that it originated in a vein. And then sometimes there'll be contents that can give you hints, whether it's a piece of an atheroma showing you it came from an atherosclerotic plaque, or if it's a myxoma, you might find a fragment of the myxoma, or foreign material. Here's an example of 2 thrombi and 2 different HeartMate 2s. You can see here behind the flow straightener, on the bearing between the flow straightener and the impeller, I should say, you can see this clot that formed in situ. But here in this example, the clot looks like this. This actually got sucked into the pump. So here's an example of in situ thrombosis in a HeartMate 2, and this is embolic to the HeartMate 2. This one, it looks like the Superman logo, but this S here is actually catheter sheath material. So this was an iatrogenic embolus from a right heart cath procedure. And this is excipient. So this is actually a crushed up pill material in an IV drug user. You can see the microcrystalline cellulose polarizes very nicely here. This is a pulmonary artery thrombus with a hair in it. This was from a patient who had total parenteral nutrition. I'm not sure how the hair got in there, but this patient had several of these with hair. And then this is a very interesting story. This is a pulmonary artery thrombus. At higher power, you can see the black, they almost look like beads. This was actually from a rupture of the right heart of a syncardia, total artificial heart. It has this diaphragm is made of several layers of polyurethane with a graphite lubricant between the layers. And when this ruptured, the graphite embolized to the pulmonary artery. So this was the right ventricle part of the device. So to conclude, a thrombus, you can look at a thrombus and try to decide whether it's real by whether there's lines of Zahn or whether you see chicken fat and current jelly, which would imply that it's more like postmortem or just procedural. You can tell how old it is by the amount of fibrin, karyorrhexis, the formation of the sinuses, and then later on the ingrowth of spindle cells, neovascularization, and amount of collagen. And sometimes you can tell where it came from, arterial thrombi being more white, venous being more red, and of course looking at the shape, whether it looks like a vessel or looks like the part of the heart where it came from, or if its contents, whether it has atheroma, things like that, hair. You can tell that it came from someplace else. And that is, with that I'll conclude. I'd like to thank the moderators and my co-presenters, and I'd like to also thank the ISHLT for the opportunity. So thank you very much.
Thank you very much. And we're going to continue right away with our third speaker, Jan van der Thusen from the Erasmus University in the Netherlands. Jan, the stage is yours.
Thank you very much, Maja, and also many thanks to Greg for providing such a fantastic introduction to what I'm going to talk about. This is a very enigmatic title I've been given. Don't call the plumber just yet. The wide world of the pulmonary thrombosis. Quite a broad title, I think. So let's get started. So what I'll be discussing are features that distinguish chronic thromboembolic pulmonary hypertension, so CTEPH, from other forms of pulmonary arterial hypertension when it comes to the thrombi and the lesions that we can find in the lung. We'll discuss some features that distinguish potentially in situ thrombosis, such as an acute lung injury from acute thromboembolism. And I'll also finish off by talking about mechanisms of ongoing damage in CTEPH, including inflammation. So if we look at the lesions, the mature lesions that we can find in CTEPH and in other forms of pulmonary arterial hypertension, such as in idiopathic types, they look on the whole similar. But if you look at this lesion here on the left, this is entirely contained within an artery in the lung, whereas on the right, that's the plexiform lesion that we know from severe pulmonary arterial hypertension. That actually extends beyond the confines of the vessel, and you can see this proliferation of vessels outside of that vessel, and it has more or less more of a glomerular appearance than the columnar-like lesion that we know from CTEPH, which is essentially just a recanalized thrombus. You can also exaggerate or accentuate this by doing an EVG stain, so looking for elastin, and you can appreciate the mature blood vessels that are formed in these type of columnar-like lesions. But other types of lesion in CTEPH can be seen to be less mature with organization of thrombus, and potentially sometimes also with formation of fresh thrombus on top of old more organized lesions. So suggesting that there may be ongoing thrombosis going on in these arteries. Outside of these lesions, of course, you can see the lesions that you would normally expect with other forms of pulmonary hypertension as well, such as atherosclerosis. I'd also like to refer to COVID-19, as has been done by Oksana earlier, where we were able to find different types of thrombosis in the lung. And this, in fact, is one of the very first reviews of abnormalities in the lung when it comes to the thrombosis. And here you can appreciate that microvascular thrombosis that Oksana was also referring to. In addition to the microvascular thrombosis, which is quite typical of COVID, you can also find thromboemboli with these lovely lines of Zahn, and that Greg has just also highlighted, but also evidence potentially of in situ thrombosis. And these are some of the cases from our autopsy studies where we can see that there are lesions which are suggestive of in situ thrombosis with eccentric organization, and then on top of that, young thrombosis with fibrinoid clots and organization. You can see that here in a higher power. You can actually also appreciate that there's a little bit of inflammation in the underlying tissue. Whereas the pulmonary thromboemboli that you see in these patients tend to have very much more the typical appearance of these red blood cell rich clots filling up the entire lumen. And if you take out these thrombi by pulmonary endarterectomy, you can see that in the organized thrombi, these appear to be yellow, and there's very little in terms of red here. In the organizing thrombus, as you would expect, there tend to be large areas of red on the surface, translating to these areas of fibrin in the organizing thrombus. And in the very mature atherosclerotic thrombi in these patients, you can see that there's atherosclerosis as you would find anywhere else in the body. Now, why is this relevant? Well, it's been shown that the morphology of these lesions can potentially predict how patients respond to pulmonary endarterectomy. So in this particular study, it was seen that if you have a columnar-like lesion, so one of these mature lesions, you tend to have a better response to that type of surgery, with the pulmonary vascular resistance being lower after the endarterectomy, compared to the types with early phases of organization of fresh thrombus or more mature atherosclerotic type lesions. This is also a study which shows something similar, but then in a slightly different composition. So we have the organized thrombi, which respond with a decrease in pulmonary arterial pressure after PEA, but it's particularly the mixed type of thrombi which seem to have the most benefit, also in terms of transpulmonary gradient and pulmonary vascular resistance. We've seen something similar in our cohort, where patients with partly fresh thrombi tend to have a worse clinical profile across various parameters, going from clinical performance, such as the NYHA status, to pulmonary vascular resistance, but also including, for instance, pulmonary function tests. So on the whole, they tend to be from a poorer performance group. And what happens if you operate on these patients with a partly fresh thrombi? They have a very good response. You can see that the pulmonary arterial pressure then actually is very similar to those which have had a completely organized thrombus removed. And particularly looking at the BNP levels for heart function, you can see that the patients who've had these partly fresh thrombi really have the most benefit from these type of endarterectomies. There's something else that goes on in these thrombi, and Greg also alluded to this. So there's some angiogenesis that we can observe. These may be in form of these little strands of endothelial cells or capillaries, potentially also in more mature vessels, also then eventually including quite large areas of media with SMA positive cells then. And if you look at the different types of thrombus, you can see that it's particularly in the thrombotic type of CTEPH that you find these small capillaries and endothelial cells. So there seems to be something going on in terms of angiogenesis, and potentially that may not actually be a bad thing. So this is a study that looked at the amount of angiogenesis found in these thrombi and looking at outcome after, again, pulmonary endarterectomy. And the higher your angiogenesis score was, the better these patients in fact performed after this type of surgery. There's not just angiogenesis that we can observe, there's also inflammation in these lesions. So CD20 stains B cells. They're very few in number, but they're certainly present. CD3 also shows diffuse presence of T cells in some lesions. CD68 is particularly prevalent in many lesions, and MPO that stains neutrophils, and these tend to be much more towards the surface of the lesions. And you can see that here as well on the right-hand side. When this study, they looked at the localization of these various types of inflammatory cells, and the neutrophils appeared to be particularly towards the surface of the lesion. This is also reflected in inflammatory parameters in the blood, so plasma levels of various pro and anti-inflammatory cytokines are raised in patients with CTEV compared to healthy controls. What is the relevance then of these neutrophils? I mean, they may have a bystander role, but they could also potentially be involved in progressing thrombosis in CTEPH, where here you can see that in this study, it was seen that in CTEV, there was an increase in the number of neutrophils in the blood, increase in MPO in the plasma, MMP9, so this matrix metalloproteinase, elaborated by these neutrophils and so on. So there's lots of signs that there's increased activity of neutrophils. And in fact, in vitro, these patients with CTEV tend to have an increased formation of so-called neutrophil traps or nets. And this is something that's also been seen actually in COVID. So it's not exclusive to CTEV. This is a study that we recently published looking at the presence of macrophages and subtyping of macrophages in CTEV, particularly comparing those lesions with an organized appearance to those with a fresh, at least a fresh component with fibrin, You can see that here on the left-hand side. So fibrin at the surface of this lesion, removed by the endarterectomy procedure, and here on the right-hand side, it's an organized thrombus. And then looking at the various inflammatory cells, we found with multiplex immunofluorescence that there's presence of macrophages, which can be either of the M1 phenotype with CD206 minus and INOS plus expression, but conversely, the M2 macrophages would have CD206 on the membrane and don't express INOS. And here we can see that in the CTEPH lesions, the organized thrombi tend to contain more macrophages, and this tends to be mainly of the M2 phenotype. Now, whether there's some causality there or whether this is a bystander effect, we don't know yet, but I think it is enticing to think that these M2 macrophages, which are known to have anti-inflammatory properties and organizational properties, may actually play a role in actually ripening these thrombi, as it were, and organizing them. They may also be important in platelet monocyte aggregates, which are seen to decrease after treatment of CTEPH. And then taking it all together, netosis, platelet monocyte aggregates, and thymocyte aggregates or T-cell aggregates may actually cause ongoing thrombosis. Endothelial cells have also been found to be activated in CTEPH by, for instance, increased endothelin-1 levels in plasma and in the cells themselves, causing also alterations in the vasculature elsewhere in the lung. So in conclusion, I think CTEPH may be a concoction of impaired fibrinolysis, inflammatory thrombosis, which we've seen, potentially deficient angiogenesis, and abnormal signaling of endothelial cells. And these, I think, offer potential inroads for treatment in the future. And I'll stop there, and thank you very much for listening.
Thank you so much. So we have already reached our last speaker for tonight. This is Cassandra Vale, who is actually a pharmacist at the Prince Charles Hospital in Queensland. Cassandra, please. We can't hear you.
Okay, yes, here we are. Apologies. All righty. Thank you, Maja, for the introduction. And hi, everyone. I'd like to thank the ISHLT for the opportunity to speak today, and for everyone for tuning in from all corners of the globe. Welcome to the Clot Thickens, Unraveling the Mysteries of Coagulation and Pharmacology. This presentation is aimed at delving into current anticoagulation strategies, but given the enormity of the topic and in the interest of time, we'll just focus on giving a brief overview of some anticoagulants, what constitutes heparin resistance and how we can overcome it, the role of anticoagulation in CTEPH, which we've just talked about, and in extracorporeal circuits, and a brief touch on upcoming factor 11 inhibitors. So, as we all know, there are a variety of anticoagulants available to us, some more geographically available than others, via both parenteral and oral routes. And generally speaking, the higher up in the coagulation cascade that the agent works, the more options there are for reversal downstream. Unfractionated heparin remains a pinnacle of anticoagulation management across almost all indications requiring rapid or parenteral intervention, but is plagued by the clinical scenario we know as heparin resistance. Now, although heparin resistance is not a rigid definition, it is accepted as a failure to achieve anticipated anticoagulation despite using an adequate dose of unfractionated heparin, and it's vastly multifactorial in nature. So, unfractionated heparin is a strongly negatively charged molecule, which is highly susceptible to sequestration via binding to a multitude of other coagulation factors, chemokines, non-endothelial surfaces, and also microbial proteins. Unfractionated heparin also requires adequate amounts of antithrombin 3 as a cofactor. And so things like severe illness, certain disease states, and the presence of, again, non-endothelial material and circuits can contribute to a relative deficiency. So we have a clinical state that may be the result of some or all of the above factors. We can consider using alternative testing with chromogenic anti-10A assays to determine if the activated partial thromboplastin time is accurate or erroneous due to fluctuations in any of the other coagulation variables. which makes sense when we look at this very, very crudely oversimplified diagram of the intrinsic pathway of the coagulation cascade and realize how many variables are involved in an APTT measurement when compared to an anti-10A. And while this might seem obvious in some centres, it's not routine practice in others. What else can we do? We can obviously change to a non-heparin agent, but we might find ourselves in a situation where heparin is the preferred or the only available anticoagulant. And so we could consider supplementation of antithrombin 3. Unfortunately, this sounds easier than it actually is. There are equations and calculators available for determining supplementation doses of antithrombin 3 to achieve a peak level of 80 to 120% of normal, but these are not robustly defined outside of the treatment of hereditary AT3 deficiency or perioperative and peripartum thromboembolism. And they don't account for the clinical picture or ongoing sequestration in the context of circuits. Most of the data available for supplementing AT3 is in the cardiac surgical population and makes it difficult to extrapolate to different clinical pictures, which is highlighted by a systematic review and meta-analysis by Zhang et al. This year that actually recommends against AT3 supplementation in ECMO patients, demonstrating no reduction in in-hospital bleeding, thrombosis, or mortality rates, with increased risk of thrombosis or mortality in certain subgroup analyses. That said, a narrative review earlier this year does recommend considering supplementation in ECMO patients who have quantitative AT3 levels less than 70% to potentially reduce bleeding complications. However, delays in testing, which we all come across, make result interpretation and subsequent management difficult. Most centres do quantitative testing of AT3, which, while providing an actual AT3 level, doesn't reflect the functionality of the factor and often takes hours to days to come back. Functional or qualitative testing can be timely and expensive if it is actually available. Finally, and probably the biggest issue that we have faced previously, is stock availability. Certainly the handful of times we've actually made the decision to proceed with AT3 supplementation, actual procurement of the product from the blood bank has been difficult. So always consider checking stock levels before going down the decision-making pathway. However, to round that out, it is probably reasonable to consider supplementation with a single vial if stock is available in patients with a quantitative AT3 level less than 70% of expected, who are on the clottier end of the spectrum, and then assess the response quantitatively and clinically. Next, we have chronic thromboembolic disease, which has already been wonderfully explained. And for the purposes of recommendations, is delineated into chronic thromboembolic disease, or CTED, and chronic thromboembolic pulmonary hypertension, or CTEPH. The diagnosis of either condition requires lifelong anticoagulation, but the question remains as to whether the vitamin K antagonists such as warfarin or direct oral anticoagulants are the agents of choice. A roller coaster begins in 2022 with the EXPERT trial that showed similar bleeding rates but higher thromboembolic rates with direct oral anticoagulants when compared to warfarin in CTEPH patients. Also in 2022, Zhong et al. Reported an increased risk of recent thrombus with an odds ratio of 2.34 in patients with CTEPH undergoing pulmonary and thromboendarterectomy who were receiving direct oral anticoagulants when compared with those patients receiving warfarin. And this was published in the 2023 Evaluation and Management of Chronic Thromboembolic Pulmonary Hypertension in CHEST. A subsequent systematic review and meta-analysis by Ishihara of direct oral anticoagulants versus warfarin in CTEPH into 2023 also concluded the DOACs were associated with significantly lower mortality but higher risk of recurrent thromboembolic burden. However, very soon after this, the Kabuki trial in 2023 demonstrated non-inferiority of edoxaban compared to warfarin in CTEPH patients post-reperfusion in terms of pulmonary vascular resistance and arterial pressures, symptomatic venous thromboembolism, and clinically relevant bleeding. A systematic review and meta-analysis by Salazar in 2024 demonstrated similar rates of all-cause mortality and VTE recurrence, with non-significant reductions in bleeding when direct oral anticoagulants were compared to warfarin in the CTEPH population. And this was supported by another meta-analysis by Zhang later in 2024. So watch this space is all I can offer. We won't spend too much time on anticoagulation and left ventricular assist devices, as the ISHLT consensus statement of strategies to prevent and manage hemocompatibility-related adverse events in patients with a durable continuous flow ventricular assist device, that's a mouthful, was only published last year. However, of note, newer LVADs, namely the HeartMate 3, no longer routinely require aspirin in addition to a vitamin K antagonist as part of hemocompatibility management, following on from the outcome data of the ARES HM3 trial in 2023. Vitamin K antagonists remain the primary oral anticoagulant for continuous LVAD devices, although another space to watch. Despite a pilot study of dabigatran resulting in increased thromboembolic events in 2017, two separate studies in 2024, the DOT-HM3 published in August and the DOEC LVAD published in September, demonstrated feasibility of apixaban compared to warfarin in carefully selected continuous flow LVAD patients without an excess of hemocompatibility-related adverse events or mortality. These studies were limited by patient selection and small patient numbers, but certainly set the stage for future studies in this area. Similarly, I won't spend too much time on anticoagulation and extracorporeal circuits. This is an area that is undergoing huge change on a daily basis and is most recently covered by the 2025 narrative review of anticoagulation management during ECMO. As we are all aware, the primary means of anticoagulation in these patients are firstly unfractionated heparin, with the alternative options of bivalirudin or argatroban, depending on institutional preference and availability. And whilst most guidelines still recommend therapeutic targets that are close to what would we consider full anticoagulation, I think anecdotally we have all seen current practice internationally diverging from these recommendations, which were already suffering from a lack of broader consensus. With the growing knowledge of primary hemostasis dysfunction directly related to the circuit, involving shear stress forces on platelet function and aggregation and acquired von Willebrand deficiencies, improvements in the hemocompatibility of the circuits themselves, as well as a recognition that bleeding-related adverse events are much more closely related with increased morbidity and mortality than thrombosis-related adverse effects. I think we're seeing shift towards lower therapeutic targets, which are not necessarily reflected in all of the guidelines. Although the 2023 ISTH guidance statement for anticoagulation in adult patients supported with ECMO and the above 2025 ISHLT narrative review do reflect these. The other buzz area is an institutional anecdotal change in choice of primary anticoagulant, namely bivalirudin, due to what we know about illness and circuit-related heparin resistance, antithrombin 3 sequestration, and heparin-induced thrombocytopenia and also thrombosis. Again, lots of work being done in this area and another space to watch. This is just a reminder that not all anticoagulants, I should say, are created equally, and to be mindful when switching agents. Bivalirudin, for instance, does not like stasis, and this video, which hopefully works, demonstrates the rapid coagulation that occurs on supratherapeutic bivalirudin on pump when stasis is encountered. Finally, the new kids on the block are the factor 11 inhibitors, which represent a novel approach to managing thrombosis. Factor 11 plays only a very small role in hemostasis, primarily being responsible for thrombus expansion. Inhibitors of factor 11 are aimed at uncoupling hemostasis from thrombosis, targeting purely the expansion of thrombus, and carry a significantly lower bleeding risk than traditional anticoagulants. Broadly, options available include monoclonal antibodies, small synthetic molecules, and antisense oligonucleotides in both parenteral and oral routes. So again, watch this space and some food for thought. That brings me to the end of my presentation, and I believe brings us to questions and answers. So thanks to all the fellow speakers for their excellent presentations, and again to the ISHLT for the opportunity to speak today.
All right, yeah, a big thank you from me as well. We have a couple of questions in the chat, and I'm just going to go through them by order of submission, and whoever feels most taken by them is free to answer them. So our first question is, are there any differences in thrombus formation related to gender? Anybody want to answer that?
I certainly don't have any morphologic insight into what the difference between thrombi according to gender, but perhaps Oksana can tell us something.
Not really. Yeah, we can't. The risk factors can be different, like oral contraceptive pills, yes, but the thrombus looks the same as as far as we can tell as now.
Yeah, so interestingly, perhaps it flashed by as I was doing my presentation, but in our baseline data for the CTEV cohort, we saw that there was a difference in the morphology in that about 3/4 of the patients who had a completely organized thrombus were females, whereas it was more 50-50 split when it came to the partly organized thrombi or the partly fresh thrombi, as it were. Quite what that means, I don't know. Whether that is actually reflecting a sort of predominance of males, or at least an equal share of males in the sort of progressing in situ thrombotic lesions, or whether there's a quicker resolution and organization in females. I'm not sure, but that's something that would need additional research.
Yeah, I think there's still lots of potential for research there. There's a follow-up question to this. Is the old distinction between white and red thrombus still useful?
I have to say that even though that's what's taught in the textbooks, I've never really found it to be very reliable. I mean, in the photograph that I showed, it seemed pretty convincing, but in practice, I think probably not. I don't know if anybody wants to play devil's advocate and argue the opposite.
Yeah, I don't know. I mean, I was going to ask you a question about this anyway, Greg. So do you think that also applies to the pulmonary circulation, where of course we're dealing with very much lower pressures in the arterial system?
I mean, in the pulmonary circulation, we so much more often see pulmonary arterial clots than venous clots.
Yeah,
I suppose, but
because in my experience, I don't think they are particularly white on the whole in the pulmonary circulation.
no,
No.
no, I don't think so. I agree with
Yeah.
you. They tend to be pretty red.
Yeah.
And I see that the next one, there is a question that has my name on it there, about the ancillary tools. You know, the question is which ancillary tools you suggest mandatory to support the morphological and chronological evaluation of thrombotic lesions. I don't want to say mandatory, but I think something that's a good collagen stain with an elastin stain. So with my institution, we don't use Movat pentachrome, but Movat's the king of stains, or the queen of stains, however you want to say. But we do use a Mason trichrome with a Verhoff elastin stain at the same time. So on one slide, you get both of those, and I think that's my favorite go-to. And certainly I don't hesitate to use it, but it may not be necessary in all situations.
Yeah, I'd be inclined to agree. I think I'd also use those, and in addition, in some cases, I found PTAH, so the phosphotungstic acid hematoxylin stain, useful if you're looking for small thrombi, which are otherwise very difficult to detect.
All right, we've got one more question. Which is the best method to assess fresh emboli in a patient with chronic thromboembolic disease, i.e. acute and chronic? Is there any place for PET-CT?
Oh, that's a difficult one, isn't it? I'm not so sure that PET-CT is going to solve this, because I don't think there is that big of a difference. I mean, I don't think it's been tried, but I don't think there's that big of a difference when it comes to the inflammatory cell content of the acute on chronic thrombi. It would be interesting to see. What we have seen is we've done a recent study again with COVID-19 patients, trying to delineate sort of acute on chronic and versus chronic thrombi, and it is also the sort of eccentric lesions which tend to be more associated with in situ thrombosis, and I think the radiologists have been quite good at using CT scans with contrast to actually make that distinction.
All right, thank you so much. I don't see any more questions in the chat. So yeah, I think our time unfortunately has come to an end. Vanessa, would you like to close the seminar?
Yes, just wanted to very much thank all of the speakers and the moderators for what I think is just, first of all, congratulations on an amazing presentation. Thank you all so much for the energy, effort, time that you put into preparing the presentations. Thank you so much, Maja, for guiding us so skillfully through the event and for stepping up and going solo with a little bit, not as much notice. And especially to Greg, to Cassandra, to Oksana and Jan for such great insights, and I've so exceptionally educational presentations, and especially to Greg, who actually put the program together for us. We wouldn't have had this program without your brainchild, so much appreciated. I think everybody here has certainly gone away with new insights. As someone who has to deal with the clots, it's nice to have that refresher of how everything starts, Oksana, and then how to sort of remind ourselves how to deal with it. And just to also thank everyone who registered and who's turned up live to support, and hopefully there'll be lots more people who'll be looking at it, certainly on this side of the world. They may not all be here, but hopefully they'll be looking at it at the recorded sessions. And just to remind everybody that hopefully you'll support us for the town hall, which the date is yet to be announced, but it'll be probably closer to January, February next year. But congratulations again on such a great presentation. I thoroughly enjoyed it, and I think everyone here will be agreeing with me.